Hello everyone, my name is Elizabeth Manns and I'd like to welcome you to the April 4th Coalition Show. This is the July 17th, 2023 edition of the show. It is the 462nd show that we have done since the closing of the North Adams Regional Hospital and the second show since the announcement of the possible reopening of the hospital. The April 4th Coalition's mission statement is we are for workers' rights and collective bargaining rights and are against tax breaks for the rich and corporations who ship our jobs overseas. We support all the articles of the Universal Declaration of Human Rights, but as the custom, we put the emphasis on Article 23 at the start of the show. Dick has number 1, Susan's going to do number 2, I have number 3, and Mike has number 4.
All right, number 1. Everyone has the right to work, to free choice of employment, to just and favorable conditions of work, and protection against unemployment.
Everyone, without any discrimination, has the right to earn pay for equal work.
Number 3, everyone who works has the right to just and favorable remuneration. In case you're wondering, that means compensation, ensuring for himself or herself and his or her family an existence worthy of human dignity and supplemented, if necessary, by other means of social protection.
Okay, number 4. Everyone has the right to form and join trade unions for protection of his or her interests.
There we go. And as is usual, we give a shout out and a thank you to Michael Putnam, who I believe is still the program director for WMNBLP 107.1. We're airing the audio portion of our shows on Fridays at 6 p.m. on the public radio station. And of course to David Fabiano, Nicole, and I know I'm going to lose the third person on the staff. Is it Andrea? Joanne. My apologies, Joanne, of the Northern Berkshire Community Television Corps, NBCTC, for assisting us in producing the show. And this is number 2 in a series that we're doing focusing on the possible reopening of the hospital and the status of healthcare in the U.S.
Right, and when we look at the articles of the human rights, the Universal Declaration of Human Rights, in a conference on primary health care in 1978, the declaration at El Alta said the people have the right and the duty to participate individually and collectively in the planning and implementation of their health care. And that's what we're trying to do. We're trying to advocate so we have some say in it, and that's what we have been doing.
All along.
On the anniversary, on the 9th anniversary of the hospital closing, we showed a few videos, and one of them we're going to re-show again. It's about rural hospitals on life support, a disaster in the making. And so why don't we watch that, and then we can react to it and see what they have to say.
Access to care in rural areas has to be involved in any conversation about public health. Yet we don't often hear about the incredible work being done in rural hospitals and the struggles they go through, even though 20% of Americans live in rural areas and depend on those health facilities. Now, rural hospitals, like all hospitals, have their share of funding and staffing issues. So when I initially saw headlines about the Rural Hospital Rescue Program, I was excited. And then I read about it and I was confused, to say the least. Let's back it up really quickly. Now, I'm not going to get into a big healthcare economics talk, but let's talk about what's happening with rural hospitals financially. Since 2010, 135 rural hospitals have closed, with the majority closing between 2015 and 2021. And it's actually getting worse. As of right now, about 450 rural hospitals are at risk of closing. And here's some alarming data. According to an analysis of the Rural Health Safety Net by the Chartis Group, 46% of rural hospitals have a negative operating margin. And in some states, it's particularly bad. In Alabama, Kansas, Missouri, and Arkansas, for example, 70 to 80% of rural hospitals are operating in the red. Now, going back to the Rural Hospital Rescue Program, the plan is to get rural hospitals to close all inpatient beds and instead focus solely on emergency and outpatient care. In exchange, rural hospitals get a monthly stipend and an increase in reimbursement. The thought is that unused inpatient beds in rural hospitals cost them so much money to staff and maintain that closing them would save on overhead and potentially prevent closures. The way this will all work, according to the Centers for Medicaid and Medicare Services, is a rural hospital would have to apply for a designation as a rural emergency hospital by essentially closing all inpatient beds. They would then be eligible for a 5% increased payment per outpatient service and a monthly facility stipend, which is set to increase in the future based on the market. Now, given the fact that for the average rural hospital, about 70% of the revenue comes from outpatient services, this plan might actually increase the hospital's bottom line. Now, CMS is yet to release all the details, including more stipulations about the stipend, but this plan is already being met with a lot of questions and confusion about how it's even rational to close inpatient services in rural hospitals. So I asked around to my colleagues from multiple subspecialties, and nearly everyone had a story in which a rural hospital needed an inpatient bed. Now you might say, well, hey, what about crash inpatient beds or long-term observation units in the event of an emergency? Well, according to a proposed rule by CMS, flexible swing beds will not be allowed for any hospital that wants that rural emergency designation. Really? Why not? I have so many concerns. I work overnight in the hospital. I often get calls from a transfer center from rural hospitals, but the patients don't always come over. Sometimes rural health doctors are comfortable taking care of patients, but just want to check in with a tertiary care center. Sometimes the patients themselves don't want to be transferred. Sometimes it's just something like an outpatient surgery that needs overnight monitoring. Sometimes weather gets in the way and we physically can't make a transport happen. I've even had situations where there were no ambulances or helicopters available, so a patient had to stay inpatient at a rural hospital. Also, look around. A lot of urban hospitals that would normally accept rural transfers are at capacity and short-staffed, and this problem's getting worse. We saw an alarming example of this during the pandemic when rural hospitals couldn't transfer acutely ill patients. This is a more complex discussion, but the rural hospital program also mentions nothing about the rural doctor shortage. In rural communities, there's only about one ICU bed per 10,000 people. 160 rural communities have no access to OB services. About 65% of rural communities have no psychiatry, and you can imagine that subspecialty care is also lacking. Simply put, I'm yet to run into one physician or healthcare professional who thinks it's even feasible to close inpatient services in rural areas. I mean, I appreciate the conversation about protecting access to care, but this solution is a little short-sighted. A perspective piece from the American Hospital Association talked about funding and protective efforts for rural areas, such as money directed to rural providers through the CARES Act and American Rescue Plan, Medicaid expansion, even increasing the resident workforce through the Consolidations Appropriations Act. These sound productive. In the end, regarding the Rural Hospital Rescue Program, I suspect we'll learn more details and there will be more provisions. But even still, I find it hard to believe that any hospital administrator is going to opt into this program unless it means the difference between staying open and staying closed, and that would be a harsh reality. But I want to hear what you all think, especially any rural healthcare professionals. What are your thoughts, concerns? I want to hear all of it. Comment below.
Now I remember this one. At the time, we said BMC had followed that model
Yes.
by closing us and focusing on an emergency care and the outpatient services. How did that work out, Mike?
What?
How do you feel that worked out? BHS focusing that way instead of keeping it open and having inpatient beds.
You asked me about.
Yeah, did it ever work out for you? Having all
Hospitals
the,
stay open.
the hospital stayed open?
Yes, they should, and they should be able to provide all the cares that people need instead of having to go to Pittsfield. I mean, if you go up here in North Adams, if I am correct, they don't have any overnight beds.
They still don't, no.
And if they don't, which means that there's a lot of people heading to Pittsfield, and some of them we never are going to know what happens. I mean, if it's very serious and they got to go all the way to Pittsfield, somebody can die.
If I recall, they have 2 observation beds. That's it.
Yeah.
but that's not an emergency, that's not an ICU, that's not
And this is
inpatient.
not a real emergency
It's a
room
room.
either, because they don't have medical surgery available, emergency surgery.
Sure,
So it's
So-
all the signs that say hospital were taken down and it said acute care,
Mm-hmm.
but it's not an emergency room.
So this means BHS is bucking the trend if they actually reopen because the critical care access part.
Right. But Susan, you had mentioned that you knew someone that wouldn't, like they talked about it in the
Yes.
video, that people don't want to go to another hospital, they might refuse to
And
go.
refuse care that they need, because there was one friend of mine who had a lesion on her face that they said was probably cancerous, and she said, well, they told me I had to go to Pittsfield. And this was just not, not an inpatient problem, but she didn't seek help because she did not want to go to Pittsfield. When she drives her car, she says that she goes so slow that people bump into her, and she's afraid of getting into an accident. And people don't have the money in this community to be taking cabs, Ubers to Pittsfield, especially in an emergency. The ambulances, it might take 45 minutes.
Yes. And
I
plus-
mean, which is, that's so crucial to someone who's critically ill. And
Right.
the farmers, they put things off. So what happens is, in a rural area there, is they have to be helicoptered out of there. And the amount of money that costs is astronomical. They lose their farms. So not just I'm talking about them losing their farms compared to also financially what it costs people to just get back and forth to
Right.
a large hospital.
And-
We
and-
need critical care beds here.
Well, I can tell you that Tony used to be a regular up at the emergency room, my boyfriend, without giving a last name because he would have anxiety attacks and whatever. And he didn't mind as long as he could stay at the emergency room and then get released out. But anytime they said they were going to transport him to BMC, he hated the ambulance ride. It just wasn't comfortable
Right.
or anything. And he wasn't so much worried about cost because he's one of the lucky ones in terms of having full coverage. But basically he hated the ride, and he didn't like putting me in a position of having to go down there
Right.
after him.
And it's not like you're going on a brand-new interstate and
Highway.
you're going 35 miles and you're going, 60 miles an hour and you're going to get there on a nice smooth road. That's
No, this is
not how
bumpy.
it is. These are roads with potholes, railroad tracks, and if you're lying on your back and just had a heart attack, I think I remember someone from Adams telling me he thought that his heart had an irregular heartbeat, and he went over the railroad tracks, and he thinks that's corrected it because they had such a big bump. But and I can remember meeting, I think, with Mrs. Radovic, and her saying that we're not going to open up beds. We have an application for critical care access. We're filled it out, but we're not going to submit it till we know that it can pass. And that was about 10 years ago that
It was,
9
yes.
years ago that
9
she said
years
it.
ago that
But
she
what's
said that.
happened now is we had our congressman was able to change the law where it said you had to have a major highway to get that 35 miles. And they think that we're going to be able to get it. So
And I think they lowered the distance between hospitals as well. If you exceeded that distance,
yeah,
you could apply for the critical care access as well.
Right.
Because I think it used to be if you were within 25 miles and Pittsfield and North Adams is just barely that now it's 15-mile difference. If
I'm
you're
not
over
sure.
that 15, you can get, that was in the article. That's
Okay.
one of the reasons they're more sure they're going to get it because
Yeah.
we're definitely not We're not even 15 miles from Bennington.
Yeah.
So-
Liz, I wanted to reiterate on one
Yes.
just point that you had made about the having stress and anxiety attacks. And we did have the Greylock Pavilion where there were some psychiatrists, you know, and therapists to help with this so that someone didn't have to go all the way to Pittsfield.
Right.
And even without the Greylock Pavilion, we still didn't have anyone there that would be able to, you know,
To help,
to
right.
really help. And the community does have a large number of people, and you just couldn't run over to the Breen Center. They can't help you, you know. So we need that also.
Right, one step at a time.
One
though.
step,
Yeah,
yeah.
First we get the inpatient beds and then we
Exactly.
can go. So the critical care access, we have a video we want to show about critical care access.
Mm-hmm.
It talks about the history of it. So let's try to educate ourselves about it. This is, I don't know if it's a year old or not, but you know, it might not have gotten the updates yet, but let's listen to that video.
There are a lot of differences between a rural community and an urban one, but the need for excellent health care, well, that's all the same. This is your community, and this is your hospital. It may be small, yet the services offered are huge because they're essential services like surgeries, an emergency room, and 24-hour health care. Without you, people may not get access to these services. This rural hospital, your hospital, is vital to the people who live here. Children, seniors, and everyone in between count on it for their well-being. But more than that, you keep your community healthy in many ways. Maybe it's a rural health clinic, or long-term care facility, or services like mental health, retail pharmacy, and EMS, or through community outreach. And you're committed. These aren't just patients. They're your friends, your neighbors, your family. But let's face it, healthcare is challenging. And even today, rural hospitals are still at risk of closure, which means patients suffer. Not only are they losing their local health care, but they're forced to travel long distances for medical help with new providers. They might give up on their health altogether. Can you even imagine? On second thought, let's not imagine that. It's too awful. Instead, let's find out what makes your rural hospital so special. But first, a very quick history lesson.
In 1997, Congress established the Critical Access Hospital Program as part of the Balanced Budget Act, which allowed small rural hospitals to become critical access hospitals and offered grants to states to help implement initiatives to strengthen the rural healthcare infrastructure. Being a CAH is a designation given to eligible rural hospitals by the Centers for Medicare and Medicaid Services.
Whew, there's a lot to unpack there. Let's take it slow. What is a critical access hospital, or CAH? A CAH is a hospital in a small rural community that must not close. It's too important, too essential. That's you, your hospital. And you're not alone. There are more than 1,350 critical access hospitals across the United States. That's more than 2/3 of all rural hospitals. The impact they and you have on the people of our nation is immeasurable. So, Uncle Sam is taking steps to help make your hospital as successful as possible. How does a hospital become a CAH in the first place? Well, let's take a look. In order to be designated by CMS, your hospital needs to be 35 miles from any other hospital, and it needs to be 25 beds or less. These beds could be acute care inpatient beds, or they could be for post-acute care, also known as swing beds. Now, don't get the wrong idea. Being a CAH isn't about having less. It's about having exactly what you need to serve your community and the people who count on you. By being a CAH, your hospital receives cost-based reimbursement from Medicare. That's huge. It means getting paid at a rate that covers the cost of the service you're providing. There's also MB-QIP, which is a program that drives quality improvements using patient care metrics and patient engagement scores. By participating in MBQuip, your hospital is eligible for various rule-based grants. Now, these grants can offer educational resources as well as technical assistance for improving quality, operational performance, and population health. Being a CAH not only keeps your hospital doors open, it ensures that your community has access to acute and outpatient services, primary care for injuries and illnesses, and diagnostic testing. It's all about keeping our friends, our family, and our neighbors healthy. It's about you. It's about us. It's about this critical access hospital. Because rule matters.
It's gonna be.
It does matter.
It does matter indeed.
And-
I argue it matters in all communities, not just
Right,
rural, because healthcare is essential
Right.
to everybody and stuff. But
in Article 21 of the Universal Declaration of Human Rights, Section 2, it says, "Everyone has the right to equal access to public services in his country." So that's what we're looking for in Berkshire County. We want North County to have equal
Well,
access.
access.
And this critical care access designation and inpatient beds would put us on a par with Fairview Hospital in South County. And we hope to have all the services that they have down in Fairview, maternity
point.
and all the other care.
And the mental health.
Fairview, it's fair for us too.
What? It's fair for us?
I was making a kind of a comment. If it's fair for Fairview, then it's fair for us.
That's
It is, yes.
Instead of our bills, like going to, when we pay our bills, it's going to Fairview Hospital now. Now it can stay here and come to North Adams Regional Hospital. But yeah, I think that critical care access is essential.
Oh, it's a game changer. If we don't get that, if they don't get it, then there won't be it. It will be right where we are
Right.
now.
But I have a feeling that they never would have made this announcement unless they were reasonably assured
Oh, I'm sure
that
that
they were.
they don't want the
They
egg
had
on the
that
face.
application sitting on that desk for 9 years now.
Right, and they've been waiting.
And they've been waiting for the time to strike, and I think this is the proper time. And hallelujah, we'll do whatever we can to help you on that path.
On that path.
That announcement came up on my iPad, and as soon as it did, I put it right on Facebook.
Yeah.
Michael, how did you hear about it?
What do you mean, closed?
About the hospital opening?
Okay, that's not good. I heard about it, but
How did you hear about it, though? Who told you?
it had to be on TV or the radio.
Yeah.
And the problem is, I want to see it when it gets all here because I don't be going back for the Pittsfield. I did that before already. I tell you, it's a hell of a ride to go all the way to Pittsfield. Then it goes so good, you come home, guess what? You gotta go back up again. So, there's no reason why we can't have a full-service hospital. Seriously, there's none. And so he said, well, because they can't find any more excuses. I mean, for people in office to protect us. That's it. And healthcare is one of the most protection we need.
Right. Well, we have a few minutes. You think it's okay to show a little newscast on healthcare for all? It's a movement for Massachusetts to get universal health care.
Sure.
Think we have time?
I was say something very quickly. is
Yeah,
that my
before we
mother-
start, what
My
would you-
mother-in-law used to say, without your health, you have nothing.
That's it.
Very true.
That's it. So why don't we show that last video on single-payer health care for Massachusetts? It's a new.
Could Medicare for All be coming to Massachusetts? 22 News State House reporter Ellen Fleming has the results on the non-binding ballot question 5.
In 20 House districts across the state, voters were asked if they support Medicare for All, and it was an overwhelming success. This non-binding policy question won in every district where it was on the ballot. Voters in the 2nd Berkshire, the 6th, 7th, 8th, and 12th Hampden, and the 2nd Franklin saw this as question 5 on their ballot. Agawam had it as question 6. The question also appeared in parts of central and eastern Massachusetts, as well as parts of the North and South Shore. The question asked voters if they supported a single-payer system that would cover all Massachusetts residents, with the freedom to choose their own doctors and to do away with the role insurance companies have in healthcare by creating an insurance trust fund that is publicly administered. MassCare, which was behind the ballot initiative, believes people are sick of seeing premium increases.
I think people are, really dissatisfied with how much they're having to forego of their budget just to be covered for health insurance. And then when they get to the doctor, they might have to pay more again.
Now, this is a non-binding question, meaning it won't become law. However, one reason non-binding questions are asked is to pressure lawmakers into supporting corresponding legislation. That corresponding piece of legislation is an act establishing Medicare for All in Massachusetts, which currently 40% of lawmakers have already supported. Working for the State House in Boston, Ellen Fleming, 22 News.
I wonder if the percentage went up after the non-binding
Yeah, well, right now,
referendum.
we know that every representative in Berkshire County and our senator in Berkshire County have all come out in favor of Medicare for All in Massachusetts. We just have to get the Speaker of the House to bring it to a vote and see what the other representatives say. But the fact that a system, everybody in, nobody out,
I think it would open eyes around the country as to what a cost saving that can be. Simply because insurance is probably 80%, is not only setting the services that you can have, they're setting the prices that they're willing to pay to the doctors and everything, and for all those services. And naturally, the doctors want the gap made up.
Right. And in that case, if it passes in Massachusetts, then everyone would have equal access to public services and health care. It wouldn't be, well, I got a really good insurance plan, so they're going to take care of me, give me all the treatment I need, and then somebody else doesn't have any insurance. Well, we don't know if we're going to cover you. Fill out this form. But, the first thing that happens when you go to the emergency room is they ask you what insurance you have. Well, if everyone is on the single payer plan, that won't be the first question.
Asked. The first question will
Everyone-
be, do you have a cold? Will be your first
Right.
question. They're
Are
going to
you
want
a
to know.
resident of Massachusetts? Yes.
Something like that.
That's all. And then you're treated the same way as anybody else.
Also, if everybody gets health care, that you can have preventative so that it doesn't get to the point where you're hospitalized and you're spending even this enormous amount of money,
Exactly.
to keep hospitals, afloat. So I think that's a great for Congress, to
And
pass.
let's hope Massachusetts leads the way again.
Let's
Since-
hope, yeah, because the Obamacare, which came nationally, first started in Massachusetts. So let's see if we can get this to pass. We only have 25 seconds left. And so
I
I
know.
just want to thank you all for coming. Michael, it's great having
Getting
you
you
with
back.
us.
Good
We're
to see
happy
you again.
that Mass MoCA has a union now. You were an employee there fighting for workers' rights a long time before they had a union. But
So
so anything to
change
say,
can
Mike?
happen.
Anything to say?
Well, without a union, you're only one voice. With a union, they're going to listen to you. And the problem here is support the unions. They're
Right.
supported.
Thank you.
Support the unions.
I've been there too.
Thank you. Okay. We're all done.
There's power in the factory, power in the land, power in the hand of the worker. But it all amounts to nothing if together we don't stand. There is power in our union. Now the lessons of the past were all learned with workers' blood. Mistakes of the bosses we must pay for. From the cities and the farmlands to trenches.